do the sex.
Today's locker room talk topic is female sexual dysfunction and how to get back to having a bangin' life in the bedroom. And my drink for the day is coffee because this is a special Coffee Talk with a Doc episode. That's right. It's early where I am now. And so I'm going to be sipping coffee while I talk to my special guest, Dr. Julianne Arena, a double board certified physician, educator, keynote speaker, entrepreneur, and mother to 2 teens whose passion is women's sexual health and intimacy. Welcome, Dr. Arena. I'm super excited to talk to you. And I would like you to take a moment to introduce yourself to my listeners and tell them a little bit why you are going to be our expert on female sexual dysfunction.
Thank you. Thank you so much for having me on this podcast. As you mentioned, right, female sexual health and wellness is not talked about enough. And we want to get that out there. So thank you for having me. My story, my background, and how I got here. I'm a conventionally trained OBGYN. I was delivering babies, doing surgeries, all of that, working with women for years and years and years. I've always had an integrative approach to things. What does that mean? Multimodality care. So in my OBGYN practice, we had acupuncture, we had massage, we had other modalities than just traditional medicine. In traditional medicine, we are taught, what are your symptoms? Here's your diagnosis. Here's your pill for your ill. So I was on that hamster wheel for years. And then in 2016, I went to a conference on integrative medicine and women's health. And there I had my aha moment. I learned so many things that I didn't learn in medical school. I learned about the gut and the microbiome and how that affects what's going on. I learned so much more about our thyroid gland and our neck. And every day I would come home from that conference, I went with my friend who's an acupuncturist. We'd go back to our hotel room and I would say, oh my gosh, we have to bring this into the practice. We have to grow another branch of the tree. Yes, we need conventional OBGYN, but we need so much more, right?
Yeah.
So I came back to my practice so passionate about bringing this in. I needed more education. I went back. I did a fellowship in integrative and functional medicine in women's health. And I said to my partners, we got to do this.
Right.
But again, if you're not out there, if you're not getting more education, if you're not researching, you don't understand it and you think it doesn't exist. So I tried and I pushed and I pushed and I started seeing women in my practice and I started asking them more about intimacy, about their gut, about their poop, about their sleep. But you're challenged in a traditional practice, right? With seeing 30 people a day. We've all experienced it. You're double booked. You get your 7 minutes with your provider. So you got to get everything out before your 7 minutes is up, right?
Right.
So I would say to patients, come back. Let's have another visit. Let's talk more in depth about what's going on. So I remember I had this one patient, we'll call her Sue. I said, Sue, let's come back. Let's take a deeper dive. And when Sue came back, she said to me, you know what, Dr. Arena, you were the first doctor that ever asked me these kinds of questions, that ever asked me about intimacy, that ever asked me about sleep and poop. And she was crying. And I get chills as I tell it now because I knew then and there that this was my calling and this is what I needed to do. So if my partners weren't on board, I knew I had to go. So after 15 years in being the president and a partner in this practice, I said, here's my resignation. So I took a big leap and I left without having a place to go. I subsequently went and worked in an integrative practice for 2 years. And then they shut those doors. And I said, this is the universe telling me I need to create my own practice.
Right.
So with a colleague, we created Waves of Awakening Center for Personalized Medicine so that I can have other people find their awakening as I did. And we did that in 2020, 2 weeks before COVID and the world shut down. So, right, we navigate and the world of telehealth, but that's where we are now. And I will tell you, during COVID, You couldn't go to conferences. But I found myself listening more and more and getting more and more educated on women's sexual health.
Mm-hmm.
And I thought, gosh, it really isn't out there, right?
No.
There are 26 FDA approved medications for male sexual dysfunction. For women, there are 2. And there's a lot of side effects with it. So I said, I need to be on the forefront of this. I need to be talking to every person who walks through the door about it, right? We are hardwired for intimacy and connection. And that gets so put on the back burner.
Right.
Right. As, I'm passionate about seeing women, and we all have this sort of what I call superwoman syndrome, 50,000 balls in the air. Everybody else is on the front burner, whether it's career or partners or children, and we are on the back burner.
Yeah.
Well, my goal and my mission is to get us on the front burner.
Yeah. Yeah. That's it. All of that resonates. I didn't know that about the Medicaid. I didn't know we got 20 medications to get their dicks hard.
Plus 20 plus.
Well,
right?
There you got it, guys. I mean, it's not like it surprises me, but it's so frustrating because like when I received your information, the topic of female sexual dysfunction alone, just those words in that order wasn't even, and I talk about sex all the time. And I hear from women and partners to women about like, oh, my partner doesn't have a sex drive. What's going, and about issues with that. And we're kind of just told that when we are having issues with libido and with enjoying sex, it's just because we're frigid bitches or, whatever. Women just aren't into sex, which I know for a fact isn't true. So I'm so excited to talk to you about it. Let's jump into it. Let's raise our glasses. Cheers. Thank you for being here. And let's talk about sex.
Absolutely.
I am going to be posting a picture on social media. The doc has an awesome cup. And you got to go over to my social media to see it. It says more orgasms, please. And I think we should all have this cup. We should all have this cup because we all want
100%.
I want more orgasms. God knows. I don't know if you know this, doctor, but I'm just going to call you doc. I am doing a 365 days of orgasms challenge right now. Attempting to have 1 orgasm every day of the year. And I have made it past the halfway point. It's been something.
Congratulations.
It's been something. I've regretted my choice many times.
Because sometimes you just don't feel like it.
No. Yeah. But I want to launch into this conversation right off the bat with clarifying for our trans non-binary community. When we're talking today, can we specify, are we talking more about cis women, or vulva owners? Well, what we talk about today apply to trans women, just so that,
Yes, absolutely. Because when you're connecting either with yourself or a partner, I think there are some foundational, concerns or issues that are relevant to everybody.
Right.
100%.
Okay. Right. So we will have some information about that. And we'll try to clarify when things are specifically about the vulva, people with uteruses, etc. But so that there you go. A little bit of something for everybody will come out of this conversation. So I wanted to start with let's talk about what is female sexual dysfunction? How does it present in women? And maybe some of the underlying causes.
It's a huge umbrella, female sexual dysfunction, right? Mm-hmm. Because it's all connected. Yes, there's a physical component to it, and we can talk about that. There's an emotional component to it. There is, under that, the whole conversation about libido.
Right.
Right. So many times I've seen people over the years, I have low libido. I have no sex drive. What's going on? And I will tell you, years ago, I went to go search for that magic pill for women or for myself, for my patients. And then I learned, okay, there's no magic pill for women. We're, much more complex.
Right.
It's a multi-layered approach. So when I talk about libido for anyone, for vulva owners specifically, how do I feel about myself? So what is going on with me? How do I feel about myself mentally, emotionally, physically? What is going on with my vagina?
Right.
Okay. Especially if someone has had babies or given birth, or as we're going into perimenopause and menopause, is it dry? Does it hurt? Have I lost estrogen? All of that. So how do I feel about myself? My vagina. What's going on with my partner? Do I like my partner in this moment in time?
Very important.
Okay. That's a whole other probably podcast and conversation, right?
Right.
Did I sleep last night? Right. I am a stickler about a few things. One of them is sleep, because we have really poor sleep hygiene with, with phones, with computers, with Netflix. I'm guilty of it too. So did I sleep last night? Okay. What's on my to-do list?
Right.
Who's in the house because COVID brought everybody home? Right. And what's on that sticky note that I have on the top of my computer? It's kind of like a 7-layer dip, right? Libido is multi-layered. So there is no magic pill. We have to look at each of the layers.
Right.
Does that make sense?
Yeah, it does.
Yeah.
I mean, there's the physical component that may just be within your body. There's emotional, whatever's happening in your relationships or, and then the mental, like all the busy stuff. And it can all. And I would say I've certainly learned more about that by doing the orgasm every day. Some days I'm like, why did it just take me 3 seconds to have, like I get off really quick. And then some days I'm like 45 minutes in and I'm like, come on, and I've been able to start looking at
because your brain is solving the world's problems.
Yeah, I've been able to look at, I hadn't thought about sleep, but of course that would have an effect. And I know for me, alcohol has an effect as well, a real negative effect on my libido and my ability to achieve orgasm. So yeah, that speaks to me. With sexual dysfunction, when we're talking about the physical, are there specific sexual dysfunction disorders that you treat?
There's arousal disorders. There's, like you said, physical disorders. I work with women. A large part of my population is perimenopausal, menopausal clients. So we work a lot with what's going on physically with the vagina. Because as we go through perimenopause and menopause, our hormone levels are shifting, right? Estrogen is going up and down every month. Progesterone is estrogen's dance partner, and that is lowering, right? Estrogen and progesterone want to dance well together. And when they're far apart, things don't feel so right. Things don't look so right. So balancing those two, looking at those two can be really helpful. I talk about them in what I call the hormone symphony.
Yeah.
And I don't know if you're familiar with that term.
No.
The hormone symphony really is, if you picture a symphony up on stage, you have the wind, you have the string, you have the percussion. All of those players are playing well together to make beautiful music. Well, we need to think about our hormones in the same way. So yes, we need to think about estrogen and progesterone and testosterone, but we also need to think about glucose and insulin. So we need to think about what we're taking in. We need to think about food and nutrition, which again is a whole other wonderful topic of conversation. But those are part of the hormone symphony. Our thyroid gland, which is in our neck, which, has to do with metabolism and all of that, is a symphony player. And cortisol.
Right.
Cortisol is that fight, flight, freeze hormone, right? It's made in our adrenal glands. It makes us the best version of ourselves, but it's really only meant for short bursts.
Right.
It's really meant for, I need to run this race. I need to make a presentation. I need to save my life. So cortisol rises. And then when we're safe, cortisol comes down. Okay. Right. What is our reality? we are in this fight, flight, freeze, if not 24/7, many more hours in the day than our body is designed. Okay, so now think about your symphony up on stage. If you have someone who's playing really loud all the time,
right,
what is the symphony going to sound like? It's not going to sound like a symphony. It's going to be like a garage band or something else. So when we're talking about hormone balancing, we need to look at all of the players. So yes, estrogen, progesterone, testosterone, glucose, insulin, our thyroid gland, and our stress response. So when I'm working with people, we have to look at all of those players.
Right, right. I have a good question that I know comes across, well, my inbox and friends' conversation when it comes to perimenopause, menopause. What can you tell me the difference between perimenopause, menopause, and here's the billion-dollar question. When does menopause end? Does it end? Like, where does this all, none of us know. Somebody's got to know. So if you have the answer, I don't know, that would be amazing.
Right. Gray zones, but yes. So perimenopause can be up to 10 or 15 years of our lives. It can start in our mid-30s. Perimenopause is when, as I mentioned, estrogen's shifting month to month. Right. Progesterone is starting to do that slow decline. So you could have a great month with symptoms and periods, or you could have a really bad month. Oh, but then the next month's better. So that can be 10 or 15 years, depending on what your hormones are doing, right? So menopause, and I think I've heard someone else on your podcast describe it. The textbook definition of menopause is going a full year without a menstrual cycle. So when we're in menopause, estrogen is usually low, progesterone is low, and the textbook definition is no menstrual cycle for 1 year.
Okay.
Then when we lump into, we are postmenopausal. So that one isn't really talked about as much. So when someone says I'm menopausal, it can also be, I've gone through the transition. I haven't had a period in a year. I'm now postmenopausal. So I often get asked too then, well, when are my symptoms going to go away?
Yeah.
And that is so individualized. Some people don't have any hot flashes, night sweats, vaginal dryness, or the 50,000 other symptoms that can be labeled as we transition. And others, it can last a few months, a couple of years, or even longer, depending on what your whole body health state is in.
So when you're postmenopausal, do symptoms stop and then you're just at a new normal?
Ideally, yes. But do I have women who experience hot flashes, night sweats, vaginal dryness past that year-long, I haven't had a period in a year? Yes. But again, hot flashes and night sweats can be because our estrogen is too low. It also can be our estrogen is too high in relationship to our progesterone. And it also can be because our cortisol, our stress hormone, is high. When I have someone coming in saying, I'm dripping sweat at night, all of that, the immediate assumption is, oh, your estrogen is low. Well, no, we have to test and not guess, because what if your estrogen's actually high? Because there's so many things in our world that are toxic and act like estrogens. Mm-hmm. So your estrogen could actually be too high, causing hot flashes and night sweats. Or your cortisol, your stress hormone, is crazy high. And who doesn't have that?
Right.
Right. So it's really about individualizing and not just making assumptions. Oh, your estrogen's low and here's your estrogen.
Right.
I mean, I'm a huge proponent of bioidentical hormone replacement customized to the individual, but we have to test and not guess.
Right. Okay. So That's interesting. I didn't know. I always thought of the hot flashes as being like, so I am on an estrogen patch right now, which was the fix, right? It was like, you are, I was miserable. I will say now in retrospect, I realize, and this was at the beginning of my 365 days of orgasms. I was in this amazing sexual relationship with my partner. And I had been kind of horny the whole time, the whole year before. And then and I was going through some shifts. I was having a hot flash here and there. It wasn't regular. And then all of a sudden I tell people, I would find myself staring at a wall for like 40 minutes, just staring at a wall and kind of come back to, and I'd be like, what the fuck? I just lost like 40 minutes of my life and I don't know. I was forgetting a lot of things. I felt like it was in a fog. The hot flashes were coming a lot. And I think the biggest thing for me, that I wonder how many other women identify with, is I felt uncomfortable in my skin. Like I actually felt like my body was foreign to me. It almost felt just gross walking around in my own body. I know that sounds strange, but it felt like an outfit that was the wrong size. And I started to struggle in confidence in my relationship. I started my sex drive. Definitely. It was taking me forever to orgasm. It was so, and of course this happens right as I start this journey of having an orgasm. I could 45 minutes, an hour by myself with like 7 different toys. I'm like, what is happening? And so I did. I got on. Right. I was like, I don't care, And one thing I think we should talk about is, a lot of women have been told taking estrogen as a risk for breast cancer. There's a lot of fear and a lot of women who are just so anti it. Yes. And I went in and I was so miserable. I was almost at the point where it was like, I just can't, like, whatever, I'll take whatever risk. I need my life back. So I want to know how much this matches up with what the doctor I sat with talked about. She was like, she says that idea that adding estrogen will just, increase every woman's chance of having breast cancer isn't accurate, that it came from one study that was really blown out of proportion. Does this match up? So I want to hear what you have to say. Judging by your reaction, you agree.
Oh, right? Can you see my face?
Yeah.
I am so passionate about this because, right, I'll explain a little history and what happened with this. So we age because our nutrients and our hormones decline, okay? Mm-hmm. So definitely there's that adage of, oh, you're just getting older, right? No, right? Let's optimize. So, the generation before us, there was hormone replacement therapy, okay? Right. The world of what's called Prempro. So in pill form, it was a synthetic estrogen made from horse's urine and a synthetic progestin, okay? Pill you took by mouth. So perhaps, our mother or grandmother's
can we back
generation.
up just a sec? Can we just back up to the horse's urine? So they weren't...
Ethylene estradiol, right, was created through mare, like horse's urine.
What was it called again?
So ethylene estradiol from horse's urine. Yeah. So that was what was in Prempro, which was the big, my mom took it, so that generation. And it did help, right? Because estrogen protects our brain, our bones, our heart, right? We have estrogen receptors from our head to our toes.
Right.
So when we lose that, it's not just in our vagina. So that was what was out there in the pharmaceutical world. Then in 2002, which I think is the study that you're talking about, the Women's Health Initiative said, whoa, okay, there's risk. There's increased risk of breast cancer, of clotting, of, increased risk stroke, all of that. They didn't say that, wow, there's actually benefits with brain function and Alzheimer's and decreased risk of colon cancer, because big news makes big media, right?
Right.
So everyone said, come off your hormone replacement therapy. So there was big hoopla around that. Many women were then miserable. And then what they've done over the last 20 years is looked at that study. It was synthetic hormones. The population was an older population.
Right.
Some were smokers. So you cannot put all of that information widespread to everybody. Right. So you hear this conversation about synthetic or conventional hormone replacement therapy, and then you hear the topic of bioidentical hormone replacement therapy. You may have heard those terms.
Yes.
What does bioidentical mean? Just the same chemical structure that our body makes.
Right.
So if you are taking an estradiol patch, that estradiol is the same chemical structure that your body makes. It's not from horse's urine. Okay. If you're taking, yay.
It kind of makes me feel better. Yeah.
Right. If you're taking progesterone, true progesterone, not progestin, which is a synthetic, which is what's in a birth control pill, which is what's in Prempro, which is what's in a Mirena IUD, that is synthetic. True progesterone in studies has shown to be breast protective. So if you're taking transdermal estradiol in a patch or in a cream and true progesterone, that risk, all those risks, much lower.
Okay. Yeah.
And actually can be protective. Again, women, the number one killer for women is still heart disease. I know breast cancer is really important and it gets a lot of attention in media, as it should. But we still die more often from cardiovascular disease and heart disease, and estrogen is cardioprotective.
Interesting. Yeah. That was this is what I'm hearing more and more of, but it's interesting from doctors, but it's interesting when you talk to women, they are not hearing that. They're afraid of the patch, and they are being, and there is this real, I feel social pressure to be, you will be the best woman you are if you just like get through it. If you just embrace the change, there is this idea.
Suck it up.
And I feel like that is like throughout my experience as a cis woman, that's been the message. Like your period's painful. Like that's just how it is. Take some ibuprofen, but get up and, this is just part of being a woman, to having children, obviously. Like, and if you have a natural childbirth, you're a better mom. Now I did have natural childbirth. I also had an unnatural one. And in the end, I was like, God damn, whatever gets a woman through this shit is what gets her through it. So much around the stuff we go through is like, just suck it up and get through it. And I'm like, why do we treat women this way? And then when it comes to menopause, it's the same thing. Be the better woman and embrace menopause and just go through it naturally. And you know what? Fuck that. I was doing that and I don't think I could be doing this show right now, frankly, in the state of mind I was in. And menopause is actually, along with if you are in a relationship, hurting your sex life, it just like your quality of life can really diminish, So
true. So true. That mentality of, and even my colleagues, this was part of my impetus to speak more and get out there. Even my colleagues say, well, yeah, it's menopause. This is what's to expect. Here's maybe one or two tools in the toolbox. That's all we have, and you'll get through it. Well, no, I want to be a rock star in my 50s, 60s, 70s, 80s, and beyond.
Yeah.
I don't want to just be told,
right.
And nor do I want my patients to be told, yeah, you're just getting older.
All the time I hear that. Yeah. So cheers to that. Let's do our cheers, and then we're going to take a quick break. So cheers. And when we come back.
Cheers, my friend.
We are going to talk about menopause and how it affects sex drive, our body sexually. And then we're going to start talking about some of the solutions that are out there for all the sexual dysfunction that women face. So we will be right back.
Fantastic.
Annette Benedetti here, the hostess of Locker Room Talk and Shots. If you love the show but want just a little bit more, head over to our Patreon page and become a member starting at just $2 a month. Along with directly supporting the show, your membership unlocks exclusive content, including access to my 365 Days of Orgasms diary and follow-up podcasts that reveal exactly what happens when me or one of my guests tries one of those kinky things we discussed. You also gain access to monthly streaming conversations, discounts on merchandise and sex toys, and even an opportunity for a one-on-one discussion with me and a chance to be a guest on the show. So just go to Patreon, patreon.com/Locker Room Talk Podcast, or scroll down to the episode notes for the link. Head on over there and sign up. I promise you won't regret it. Cheers. All right, we're back. All right, we are talking to my special guest, Dr. Julianne Arena, and we are covering sexual dysfunction, how it shows up in women. Getting back to, we're really kind of deep into perimenopause, menopause, all that fun stuff, and hormones, symphony, the hormone symphony, correct? Yes. So we've talked about the problems. We've talked about sort of the social pushback against women who want to find a way to alleviate what comes with perimenopause and menopause. Can we talk specifically about how this stage in life affects women in their sex lives? Let's just dive really into the sex end of it, and then we'll talk about some of the solutions. So how do you see it most affecting sex and sex lives?
I see it present, as I mentioned, with decreased libido. It's, I have no interest. I feel bad for my partner. I don't know what's going on. I don't know what to do, right? And just as we talked about libido is multifactorial, what to do is sort of a multi-layered approach. Right. So where in those layers do we need to work on? Is it self? Is it vagina, which is huge. As we lose our estrogen, the vagina kind of likes to shrink. The tissue doesn't have as much blood flow. It's more like cigarette paper. And so any friction-laden event there can be painful.
It's called vaginal atrophy, right? It's a new thing I heard about. It scares the shit out of me.
Atrophic vaginitis was the previous term. That sounds lovely. Now it's genitourinary syndrome for women in menopause.
Okay.
Giving it a technical term, it's ouch, right?
Right.
So with regards to the vagina, what's out there? So it can be something basic like an over-the-counter lubrication. I'm a fan of that, and it can be in your home. It can be coconut oil. It can be olive oil. It can be your favorite lube. And there's more and more brands and companies that are coming out. I'm a fan. I like Uber Lube. And I think I had heard you mention on another podcast that as well, because it's just clean and non-sticky and doesn't have odor. And you can use it in your hair. You can use it for chafing. It's a multimodality approach. So lubrication, if someone says those things don't work for me, we can step it up. The next level to helping our vaginas is things like we can replace vagina estradiol. We use other hormones like DHEA vagina. Mm-hmm. We also can consider, which isn't thought about a lot, pelvic or physical therapy. And people say, what is that? They think of physical therapy as I have an injury, I need recovery.
Right.
Well, our vaginas need recovery too sometimes. So pelvic floor physical therapists are specifically trained down there. And we have muscles that are all interconnected through the vagina, down through our rectum, through our urethra and our bladder. So a lot of times what's happening, not just with our vagina, is happening in menopause with things with our bladder and urine. And the muscle or muscle dysfunction down there. So pelvic floor physical therapy can be another modality that I send people to because the muscles may be really tight down there.
Mm-hmm.
We're all told to do our pelvic tilt and hold everything in, or even do our Kegels for bladder. But, are we doing our Kegels correctly? So those muscles can be very tight.
Right.
So working with a pelvic floor physical therapist can also help as an approach. Then we also have other modalities that we mentioned earlier, such as Cliovana, and we also have the O-shot, and I can talk about those.
Before we move into some solutions you have, I have a question about this that I had noticed when I started to get into menopause. I'm a runner, and I'd start running and I'd start feeling like I needed to pee constantly. I couldn't run more than a mile or two, and I didn't need to, but it felt like almost like a UTI, except not exactly. And no doctor said anything about this, and I had to dig, and I found one little place in one little article where it was like, oh, menopause might cause some irregular bladder fillings. That's right?
So yes, menopause, one of the things that we also can experience, right, is things going on with the bladder, as you mentioned. So age is a factor, how physically active we are. If we've been pounding and running or aerobics can be a factor. If we've given birth and how big those babies were and what they've done to our vagina and urethra. So the bladder is definitely affected. As I mentioned earlier, we have estrogen receptors all along our body, including our bladder, right? So as estrogen decreases, we're seeing issues with the bladder as well. We can see frequency, we can see urgency, we can see a little bit of incontinence. It's called stress incontinence when we cough, sneeze, run, or urge, right? Gotta go, gotta go, gotta go. There are pharmaceuticals out there that can help that. You've seen those commercials, gotta go, gotta go. They work. They do have a lot of side effects because they work by drying things up. So not only are they drying up your bladder, they may be drying up your vagina, your eyes, your mouth, your mucous membranes, right? So if we're looking to help both the bladder and the vagina, these two modalities, Cliovana and O-shot, can do that. So Cliovana is a wonderful non-invasive modality to improve blood flow and nerve endings. And how it does it is it's I actually have my Cliovana machine right here behind me, but it is non-invasive. It brings blood flow through gentle suction, through pulsed frequency, and through vibration. And it's an easy 4 treatments twice a week, 10 minutes or less
and it's
procedure.
It's on the
with no needles, no numbing, no anything.
It's on the vulva and clitoris and that area. That's where you're treating?
Correct. Nothing goes into the vagina. Yes. And by bringing blood flow there and nerve endings, we're improving frequency and intensity of orgasms, blood flow to the vagina. So improved sensation, improved lubrication, right? So again, another multimodal way to improve. So Cliovana, and I've seen fantastic results for frequency, intensity of orgasm, lubrication, all of that. I've actually seen some bladder, even though it's not marketed for that, some bladder improvement as well. The difference between Cliovana and the O-shot, the mechanism of action is a little bit different, and it is invasive. It is a shot. So it uses what's called PRP, which is platelet-rich plasma. So it's the part of our blood, the plasma, that has growth factors and stem cells. So you hear all about stem cells and people who are getting stem cell infusions and all of that. But this uses your own body's growth factors and stem cells. So it's used all the time in sports for injuries, in hair, in the aesthetics world. But for the bladder and the vagina, it's called the O shot, the orgasm shot, because the shot goes at the clitoris and in the vagina. So you get sexual benefit as well as bladder benefit.
Well, that's where you get the shot.
I've had an O shot. Yes, so everyone goes, eek, shot. And my clitoris, no, thank you. But we have a very good protocol where we numb the area prior,
right,
in multiple steps. So it is very tolerable and no downtime and out the door,
right,
right afterwards. So 2 different options working a little bit differently. Some people layer both. They may get an O shot and then a few weeks later get Cliovana. So we're hitting it multimodality ways.
Okay, I have a very immature question, but I think one that's in everyone's mind. With the Cliovana, you said
Sure.
you use like there's suction, there's sound waves, right? Is that one of the things that's happening with it on that area?
Pulses, yep.
Do people orgasm while you're doing it?
That is a great question. And potentially you can.
I was going to say,
So
sounds like my toys.
Right? As I'm going over the instructions, there is the possibility. I have not experienced that with any of my clients, but that is a potential because it's stimulating to the area.
Okay.
Absolutely.
All right. Because I was like, that sounds a little bit like my clit sucking toys that I use. And I'm like, sometimes I'm like 5 minutes in, I'm done. So, but yeah. I know in the back of people's mind, they're like, oh my God, what if I have an orgasm? What if, how would you handle that? That's a what if, I'm sure. Like you go in there, you've had nothing going on down there. You get up in the stirrups. I assume there are stirrups involved, right? You got your dock in between
your legs. You don't have to, but as a gynecologist.
It would be nice. And your gynecologist, wonderful woman that she is, comes in, is treating you, and there you go. You have an orgasm. Are you just like, hey, it's all right? Or what does the doctor do to handle that situation?
Yes. Yay. Great for you.
You high five.
But if you're high five, right? Because, right. But also with respect, right?
Of course.
If I want to make someone feel comfortable, I can turn away. We can do whatever is most comfortable.
Yeah.
But if our goal is to bring on orgasms, again, we're doing it. This is fantastic.
Right. That's awesome. Yeah. That's awesome that there is. Now, how long does a treatment the effectiveness of that treatment last?
The research and studies say you can continue to see improvement, continued as far as 3 months out, but then lasting up to a year. Are there people that get sort of a boost before that, or certainly afterwards? They can, but not the 4 treatments, just sort of 1 treatment.
So it's something that you would do annually, basically. It would be an annual sort of upkeep scenario, right? And you're saying that both of these treatments increase sensitivity, the potential for orgasm, also wetness. Is that true?
Yes.
Okay.
Yes, I've definitely seen that anecdotally in my patients. Okay. Right. We have surveys. We do a before survey, a 3-month, a 6-month out survey. So we can, again, get the data, get educated and learn so I can share with others. This is what we're seeing. Right. These are the benefits.
So outside of women who are in menopause, who are some other women that might need these treatments, who might also benefit and have conditions that require this kind of treatment?
Any person who wants improvement with intimacy and orgasm and all of that. It's not just, we're speaking a lot about the perimenopausal, menopausal population,
right?
But I see, younger people who still struggle with that, who struggle with libido, who struggle with achieving orgasm. And what's going on with that person? Are they, if they're concerned about pregnancy or they're on the birth control pill, that can for some be a huge damper.
Yes, it can.
In libido, in sex life, in ability to achieve orgasm. So yes, we're preventing pregnancy, but what other things, what are the other side effects of that? So I do see people in their 20s who struggle with that, in their 30s. It's not just a perimenopausal, menopausal issue.
Right. So this would be a treatment that anyone with a vulva, clitoris, vagina could receive if they're struggling to get aroused, to feel aroused and feel sexual, and then to achieve orgasm.
Yes, absolutely.
Right. Now, the O shot, you said it uses the person's own, you said blood platelets, correct? So does that mean you take something out
Yes.
of the person and then put it back into their clit and their vagina?
Great question. Yes, we draw blood from your arm. So it's a simple blood draw from the arm. And then we use a centrifuge to spin it down to get that platelet-rich plasma, or liquid gold, if you will. And then that is injected at the clitoris and inside the anterior vagina for bladder benefit. So one is non-invasive, one is more invasive, but protocol to make it comfortable.
So when you say to improve the bladder, is that bladder control, or what does that mean?
What does that mean? So depending on what's going on for someone, frequency, urgency, a little bit of incontinence. Again, if your bladder is prolapsed or hanging down really far, it's not going to fix that.
Right.
That, we may need to talk about other ways, but if it certainly can improve a little bit for that, but definitely frequency, urgency, a little bit of stress incontinence, lubrication, vaginal dryness. Yes.
Okay. All right. So that's great that they sound like two really reasonable options for women who are looking to boost their sex lives and enjoyment. More importantly, just their own enjoyment of sex. Now, I want to talk a little bit about hormone replacement therapy. So we're kind of moving into a different area. I think you've got and we talked about it a little bit in menopause. My question is, I have a lot of questions around that as far as are we only talking about during menopause? Is this something that, like, maybe a woman in her 30s, can you look at someone's hormones at any time in their life and see if they need some help with hormone replacement therapy? Or is this, again, only something that we really look at in menopause?
Great question. No, it can be at a much younger age too. What often happens is in our teens, when females are starting to cycle, there is this mentality of, I've got to get a period every month, and it's got to be short and light and great. So as we develop and we mature, some get periods later than others. Some are heavier than others. And there's this perception of, we need to get it, and it needs to be like a textbook. So when it's not, and we go to the provider, often young women are put on the birth control pill as young as 11, 12 years old. And what that's going to do is give you a short, light, fake pill period, sometimes for 20 something years, until someone may choose to go off to have a baby. What I tell people is that your menstrual cycle is like a vital sign, just like your blood pressure, just like your temperature. So when your menstrual cycles are off, that's a flag. And we often just band-aid it. So you get your short, fake, light period when there could be hormone balances going on in our teens, in our 20s, in our 30s. So the birth control pill is often just used as that band-aid. How I prefer to look at it is try to get to root cause, and why are your periods doing what they're doing before we band-aid it. So to your point, are there imbalances in our hormones? Can there be? Absolutely. Where is our estrogen? Where is our estrogen compared to our testosterone? Because remember, I mentioned they want to be dance partners. Where is our testosterone? Because there is, something that's very common called PCOS, or polycystic ovarian syndrome, which has to do with imbalances in our hormones and can affect our testosterone. So what is going on there? So again, looking at all of the different hormones, including glucose and insulin, coming back to that hormone symphony, looking at cortisol, our stress response. We all have stress at any age, teens, 20s, 30s, never mind perimenopause and menopause. So looking at all of those and seeing where we can balance. So to answer your question, sometimes estrogen is off in our 20s and 30s. Progesterone may be off. So supporting that, supporting that verbally, supporting that with hormone replacement is definitely an option.
Okay. Yeah. And so if somebody came to you who was younger with concerns about their hormone balance, what would you do? Would you check the hormone? Is there a way you can check where the hormones are at? Because I'm going to tell you, I've had doctors tell me when I've asked multiple doctors, to test my hormones. They've said, yeah, we don't really do that because hormones just are changing all the time. So if I test them now, they're going to look different. So this resonates with you. And so no one has ever been willing to test my hormones. So I've just been like, well, just hand me over some estrogen. Just give me this then. But so what is your response to that?
My first response is, what else is going on in your life, including what's going on with your gut and your nutrition? And everyone goes, I don't want to really talk about that. But I will tell you, when I work with people on improving their gut health and their digestion, hormones seem to fall into place a little bit better. Not always.
Right.
If they're not, then I do test their hormones throughout the month, right? If you do a blood draw on one day of the month, yes, that will give you where those ranges are supposed to be at that time. But then what happens the week before and the week after? So I really like in that population to do saliva testing of hormones throughout the cycle.
Right.
On, 4 or 5 days in the first part of our cycle, which is called the follicular phase, and then a few days in the second half called our luteal phase. And then we map it out. And where do you fall along that? And where are your imbalances? Where's your testosterone? Where's your cortisol? So you get a bigger picture. Because if you check it on one day, that's one day, to your point, when your hormones are going up and down throughout the cycle.
Right. So why not test us more? I think just saying, well, if I do a test now, it's not going to tell me anything. Well, why wouldn't you then take the time with women to test them, more often for a longer period of time and then give them answers? And instead of doing that, it's just like discarded. So that's wonderful to know that there are some providers who will take the time to actually work with you and figure out what's going on with your hormones. Now, the big question is, what do you want to know about my poop? You've brought up the poop. I want to know what this poop thing is all about. Want to tell me about poop?
Oh my gosh, right? I talk about poop all the time. So, right, we have to poop, right?
Yeah.
We have to poop. That is one of our, our major detoxification organs. That's how we get rid of our hormones. It's our kidneys, it's our liver, it's our bowels and stool, it's our skin, right? If we are not pooping, we are not getting rid of our toxins. And they are recirculating through our liver. They are binding things up. They are causing lots of problems, including hormonal imbalance. So if you're not pooping every day, there's a problem.
Right.
So, how do we improve that? With foods, with nutrients, with moving our bodies. We have to poop.
Right.
I had one patient who was pooping maybe a couple of times a week.
Ooh.
And we created a plan of action for her, including my most favorite nutrient, which is magnesium. And I said, when you come back and you are pooping every day, I'm going to get up and do a jig.
Yeah.
And she came back and she said, Dr. Arena, I am pooping every day. Get up and do a jig. And so I did.
and that improved.
So having daily bowel movements is key.
Right.
Yeah. Like I mentioned, magnesium. I feel like I want to get a shirt that says, "Don't fear the mag,"
Yeah.
because magnesium is a nutrient that's involved in over 400 functions in our body, 400 reactions, and we chew it up with stress. So include magnesium in your foods, include it in an Epsom salt bath, include it in the Mag Calm powder that you see everywhere now, right? And the only thing, right, if we take too much magnesium, our stools are going to get looser. Well, yay, because we're pooping now, and then we know we need to back down on our magnesium.
Right.
So someday I'm going to get that little t-shirt.
Yeah. And I've only recently heard, like, magnesium hasn't really been talked about a lot. And I've only recently started to see it pop up here and there. And I worked with a health coach for a while who I have like restless leg syndrome at night and suggested it. So if you are having problems sexually, you're not aroused, something to look at is how much you're pooping. It's one of the things.
100%. We need to poop. We need to sleep, right? Mm-hmm. Sleep is part of that, multi-layered dip of libido, right? If we're not feeling good about ourselves because I'm bloated and I'm constipated and all of that, I don't feel like sharing with myself or a partner or anybody, right? So it's all tied into intimacy.
So now is the gut part of the, is the poop part of the gut health thing you were talking about? Or is, when you say microbiome and gut health, what does that mean? What is that about?
Sure.
Yeah.
So the microbiome are the billions and billions of good bacteria that are in our gut. We have more bacterial DNA in our body than we have human DNA. So it is a playground in there of good and bad, right? So we can feed it and fuel it with healthy foods and healthy lifestyle, or we can feed it and fuel it with not so great healthy foods and healthy lifestyle.
Right.
But that microbiome, when it's healthy, so many other things are better. So what I say, healthy gut, healthy brain, because there's a gut-brain connection.
Mm-hmm.
Healthy gut, healthier hormones, because of the hormones involved throughout the body. Healthy gut, healthy immune system. 70% of our immune system lines our gut or our GI tract. Oh. We are coming out of, hopefully, this pandemic. Happy gut, happier immune system.
Right.
So I've been singing for 2 years about improving our gut and our digestion so we can make our immune system as strong as possible for whatever's coming down the pike. Right?
Right. What are some of your top 2 tips for keeping your gut healthy?
Eating real whole foods.
Mm-hmm.
Staying away from the processed foods. Fruits, vegetables, lean meats and proteins. If you're, vegan or vegetarian, getting your proteins elsewhere, obviously. But whole food, more plants in our diet than we have, than the SAD or standard American diet.
Mm-hmm. Yeah.
That's key, right?
Mm-hmm.
Absolutely.
All right. Okay. Good to know. All right. We have covered a lot today. I'm feeling good about this. We learned about, sexual dysfunction actually exists in women, and it is something that can be worked with. You aren't just going to age, get old, and I think our culture really attaches sex and sexiness to youth, which it kind of sucks because frankly, during my 40s is when my libido kind of hit the highest. And then, as we get older, women are dismissed as like no longer sexually viable, which is not true. So it's nice to know that there are things that we can do to maintain our sexiness, our libido. Let's do this. I like to sum up my podcast with all the takeaways. So if someone came to you, like they're not getting turned on or they're having painful sex, let's just talk about kind of their takeaways. What are some things you would say, okay, this is what you're struggling with. Here's what I'd suggest you do right now to start making it better right now. Next steps, basically.
I'm going to ask them about their sleep and their poop, right? So I'm going to ask them about their gut, right? But then, doing some testing and not guessing. Let's see, what your hormones are doing. If you're still cycling, what's going on there? If you're perimenopausal or menopausal, what's going on? Let's test, because we're all different, right? So we want to customize and get to the root cause of what's going on with the individual. We're not all cookie cutter.
Right.
Right. So I get a good history. We do an exam. If there's things going on with the vagina, let's see what's going on. We do some testing, and then we create a plan. Which one of those layers do we need to work on?
Right. Now, so where are you located again?
I'm in the Northeast, south of Boston, in New England.
Right. So I'm in Portland, Oregon. Someone in Portland is having this problem. Mm-hmm. She can't get turned on. She goes to her doctor, and her doctor gives her the answers that most of us get, right? Yeah, you're just getting older, right. Or, hey, we can slap on a patch, or you just got to get through it. What advice would you give to that? Can they reach out to you for long distance care, or what is out there? Because not all doctors are like you. That's just the reality. Most of us don't run into someone who talks to us like this. I haven't, and I have gone to, I would say somewhere between, over the course of the last 5 years, easily between 5 to 10 doctors. And I've never had this conversation. I've never heard of Cliovana. I've never heard of the O-shot. I've never had someone agree to test my hormones. I've been rejected on that so many times. So what would you say to that woman?
Right. Great question, because I have colleagues who just, whether it's they haven't shown interest or they're on the hamster wheel and they haven't gone out to get educated. So, someone can connect with me, or I can try to link them to someone in their area who has been connected, who has a more integrative functional approach, who is trained and is an expert in bioidentical hormones, instead of being just told, oh, you don't need that, or that's dangerous, it's going to give you breast cancer. No, someone that's educated like myself. My goal is to get more of my colleagues educated and on board with this as well, because we need it. Mm-hmm. So finding someone, actually, in the Northwest, I feel like there's more of an open approach to that. The Northeast, we struggle with it, right? We in Boston have a medical mecca, but it's a very conventional medical mecca.
Right.
So I'm often encouraging my patients or clients to have more of an open dialogue with their primary or somebody else, or I'm happy to help them out with that. Again, if you don't have the training or the interest, you're just going to poo-poo it and say, well, it's not really relevant. Right. The reason they say, well, your hormones change all the time is, I don't know what to do with it, is what they mean. Right. So they're changing and they're just changing. Well, yes, they are changing. And how can we look at that?
Right. So can you share your contact information for listeners, or your website? I will, of course, put all of Dr. Arena's information in, when you scroll down, in the notes here. But just for listeners, how can they find you?
Absolutely. Yeah. My practice is called Waves of Awakening Center for Personalized Medicine. So you can find us on the web at wavesofawakening.com. We are on social media. Our Instagram is Waves of Awakening MD, and we have a Facebook page as well, Waves of Awakening. So I love connecting and opening the eyes of so many more people and women, and it's my passion. So absolutely reach out to me. If we can't connect in this area, I can connect you with other colleagues in different parts of the country who are like-minded and who think this way. Because my goal is, right, we want to live optimally.
Yes.
And healthy as we age.
We do. We do. I'm so grateful I had the opportunity to have this conversation with you. This is all new information to me, and God knows I'm looking up sex stuff like all of the time. So it's, when I find out there's something that hasn't even been on my radar, I'm like, well, if it hasn't been on my radar, then it's most likely not on most women's radar. Listeners, listen up. This is some big news. This is some great news. If you have more questions for the doctor, you need clarification, please take time to reach out to me. My email is Annette, ANNETTE @sheexploreslife.com. I will connect with Dr. Arena, and maybe even I'll be able to talk her into coming back and talking to me. So please feel free to send me questions. You can find me on social media, Locker Room Talkin' Shots on Instagram, on Facebook. My personal Instagram is being Benedetti. I'm also on TikTok. You can head over there. It's Locker Room Talk Podcast. I think that covers the bases. Also, if you want to support this show and support me and continue to get wonderful guests on the show, more information you haven't had before, please head to my Patreon. It's patreon.com/ Locker Room Talk Podcast. You can sign up. You can get ad-free episodes for just $5 a month. That's less these days than a cup of coffee. So consider it. I'd appreciate it. Thank you again for joining me, and I will see you all in the locker room. Cheers.